Hello and welcome everyone joining us today for another Agma Bone Cement Academy event. My name is Elisheva and I am the moderator for today's webinar. Today we will be focusing on potential mistakes with bone cements and how to avoid them. The webinar will be accompanied by an extended Q&A session, so you are welcome to place your questions by clicking the Q&A button. And now I have the honor to introduce our speaker today, Dr. Amos Yahav. Dr. Amos Yahav DMD graduated from the Carol de Villa University of Medicine in Bucharest, Romania in 1992. In 1993, he established a private clinic limited to implants, oral rehabilitation, and aesthetic dentistry in Netanya, Israel. He serves as a guest and keynote speaker at international conferences and professional workshops worldwide and has spoken on 4 continents. Dr. Yahav is a serial entrepreneur whose practical way of thinking combined with creativity have enabled him to develop a variety of efficient professional tools, accessories, and materials for implants in the surgical field, including the invention of biphasic calcium sulfate. He also serves as an advisor for international companies in this very progressive field. Dr. Yahav is currently the CEO of Agma Biomaterials. Dr. Yahav, the stage is yours.
Thank you very much, Elisheva. And hello, everyone. Good morning, good afternoon, good evening, wherever you are. And in the name of Agma Bone Cement Academy, today I'm going to present my presentation regarding some tips for success, what to do and what not to do when we are working with bone cement. And special thanks to Dr. David Baranes, who shares some of his cases with me today. Okay, so when we want to start working with bone cement, I assume that some of you are already working with it, maybe some of you are not yet. So we should know that bone cement is a completely different concept than traditional grafting. Therefore, we can realize what can be the specific errors for bone cements. So first thing, we start with the storage. It's very important that when we purchase the product, that it will not be stored in a hot place. Otherwise, the liquid, the saline that we have in the syringe might evaporate from the syringe itself. So when you storage it in a relatively not hot place. It shouldn't be in the refrigerator, but it should be in the clinic in not a hot place. And there are different errors that might arise, and those are conceptual errors. Those conceptual errors can be due to lack of knowledge and familiarity with the product. And those can be also by applying traditional GBR protocols to bone cement, because as I mentioned earlier, bone cement work completely different than traditional grafting. And the other error that might be is mixing the technique. Some of the clinicians who know to work with the regular technique with the traditional GBR might mix it with the technique of bone cement. So if you're working with bone cement, please don't mix technique, respect the protocols. For example, we can see here some cases of error of clinicians who did them, and those are the results. Here, for example, this case, the clinician didn't compact well the material, so after 3 months when he opened the case, he didn't find bone, he finds some mushy layer. So it is very important to respect the protocol, otherwise you will not have the result. So compacting the material is very, very important, and respecting the protocol is very important. One of the benefits of the material that it does not get contaminated due to exposure. So we are not encountering the traditional complication that we have with membranes and traditional GBR, such as infection due to exposure or losing of soft tissue, losing of hard tissue. However, we might end up with unsatisfactory results, such as here. Another mistake that is done is by placing the material and leave it completely exposed, more than 3 millimeters. Therefore, the material might wash out, and as you can see here, we have a lot of loss of volume. So those things can be avoided very easily just if we respected the protocol. The worst case scenario is when a clinician is trying to mix traditional technique and not respect the protocol of traditional technique and not respect the protocol of bone cement, as you can see here in this case. So definitely it can end up also with infection, it can end up with disaster. So it's very, very important to follow the protocol. Once you follow the protocol, you can enjoy from the benefit, and definitely you will never encounter those situations. The other errors that might happen are the surgical errors, because with traditional grafting, tension-free is a must. And the manipulation of the cement as a granules, it's a big mistake because cements work differently. And of course, with traditional grafting, we're using membrane, and here we don't use a membrane. So here you can see, for example, that for traditional grafting, tension-free is obligatory. Therefore, we dissect a large flap, we dissect the periosteum, and we try to gain a tension-free flap. However, when we do that with traditional grafting, it's completely okay because there is no other option. With bone cement, it's wrong, because what's wrong actually with traditional, with tension-free flap? When we perform a tension-free flap, actually we need to perform much larger flap than is needed. We dissect the periosteum, and then the flap is connected to the muscles movement. Okay? When you do a traditional grafting and you place a membrane, you need to stabilize it very well, and you need to make sure that there will be primary closure. Otherwise, everything will get exposed and you might lose the graft and get infected. With bone cement, soft tissue know how to migrate above the material. Therefore, we don't do a tension-free flap. The flap should be with tension, not tension-free. We stretch it to place. We reflect a minimal flap as needed, not more than this. And of course, the flap is not connected to the muscle, what gives us a better predictability. And we are not encountering the postoperative complications that are normal with traditional grafting. So if we summarize it, we can see that with traditional approach, tension-free is required. However, with bone cement, tension, the flap should be with tension and not tension-free, which means that we reflect the minimum flap and we stretch it. We don't do any periosteal releasing incision. With traditional grafting, primary closure is obligatory. Here with bone cement, the maximal closure is completely fine, which means that 3 millimeter of graft exposure is fine, and soft tissue can migrate and bridge the gap. So primary closure is not mandatory. We don't need to add any additive since the material is transformed completely to the patient on bone. Of course, we don't use a membrane as with traditional grafting, and all the procedure is by far less intrusive. Therefore, also we have a negligible complication together with the ability of the material to be a bacteriostatic material, so exposure does not lead to contamination. Of course, we cannot place the material in an acute contaminated area, otherwise everything can get contaminated. However, exposure never leads to contamination. And there are errors that can be due to the manipulation of the cement. For example, if we activate the cement before the site is completely prepared. So don't forget that cement have a setting time and a working time. So when you work with it, the site should be completely prepared before you activate the cement. Otherwise, the cement will set and get hard within the syringe, and it will be very difficult to take it out. The others errors can be in the wrong activation and handling of the cement. And during my presentation, I will show what are the wrong activation and handling. And when we inject the cement into the site, we should press it directly with a sterile gauze to compact it immediately. We shouldn't play with it. We shouldn't try to model it like granules, because it works completely different. And the other error that can happen when we work with cement is uncompacting the cement. As you saw before, when the cement is not compacted well in place, because we know that with granules, we shouldn't compact them. Otherwise, we will not have bone. But with bone cement, it must be well compacted. Otherwise, the material will not be replaced properly by the new formed bone. Now, let's see step by step. Sometimes, if we don't respect few small things, the material can come out suddenly from the syringe. For example, let's see it here. If we hold the syringe with the thumb and we don't protect the cap and we start activating, you can see that everything is pulled out. So that's something that definitely shouldn't happen. In order to avoid it, it's very simple. We place the shaft in the palm of our hand, our other finger on the top of the cap, then we push slowly the shaft until the first piston reaches the blue line, remove the cap, and now we are ready to inject it. So as you can see, it's a small mistake, but absolutely, if we don't respect it, everything can jump out from the syringe, and that's, of course, something that we don't like it to be. Now, you remember that I spoke about the compaction. This is a case when the material was not compacted after 3 months. Definitely, this is not bone. This is some mushy layer that it's a very big disappointment if we have it. In order to avoid it, it's very simple. The only thing that you need to do is to activate the material, eject it into the site, take a dry gauze, press strongly for 3 seconds. First with the finger, then with the periostal elevator, and you're done. Now stretch the soft tissue for closure. We don't perform any periostal releasing incision, not incision in the connective tissue. And you see 3 millimeters of graft exposure is completely fine. Now, after 3 months, when we open the site, we can see that we have a wonderful vital bone because the material transforms into the patient own bone. And definitely in this stage, we can drill and place our implant. And if we want a little bit more bone, we can add it in the second stage as well. So just by a simple maneuver, we can correct a mistake that was done. Again, one of the biggest benefits, due to exposure, the material never gets contaminated. But do not use a membrane. Okay? The other mistake that can be is by not being familiar with the behavior of the material, the radiographic appearance. Because normally when we work with traditional grafting, okay, we see the first day that it's radio-opaque up until the end when we open it. All the time it's appear radio-opaque. Why? Because actually 80% of the graft remain in the site. It does not transform into the patient own bone. However, bone apatite transforms into the patient own bone and is be reflected in the radiographic appearance. So first day, when we place it, it looks radio-opaque. 2-4 weeks later, we might think that we lost the material. Everything starts to become radiolucent, okay? But actually the material didn't disappear. This is the time that the osteoid is formed before its calcification. And in 3 months, we can see that the bone is there again. Now it's much more radio-opaque, but again, it's a young bone. So when you see such an image, you can be sure that everything is fine because it's a young bone. Don't expect that it will look radio-opaque like a bone that stays there for 50 years, okay? But with the time, it's go more radio-opaque and more radio-opaque. That's why the calcification takes place and the bone is mature. So when you see such an image, it's completely okay, and then you can open and place your implant. Now, there are general errors with traditional GBR and also with bone cement, such as we shouldn't work in acute infected site. We shouldn't use a fast resolvable suture, otherwise everything will get exposed before soft tissue at the time to proliferate. And of course, we shouldn't use a removable appliance on any case of augmentation procedure. Removable appliance might jeopardize the outcome. So in conclusion, the mistakes can be large flap reflection, periosteal releasing incision to gain tension free, this is a mistake. Activating the cement before the site is prepared, this is a mistake. Trying to shape the cement before pressing on it, because immediately when you eject cement, you should press on it immediately to compact it in place. If you work with it like granules and you try to shape it, it will never set. So eject it immediately after the site is prepared, and then press immediately with a dry gauze and then with a periosteal elevator. Another mistake is leaving the cement after its application into the site without immediate pressing, as I mentioned earlier. And of course, uncompacting the cement, it's also a mistake. We should compact it. After that, we compact it in place. We should suture, stretch the soft tissue and suture it immediately to close. Don't let it there for 10, 15 minutes to be open, because the material then will start break and some of it will wash out. So what you need to do after placing the material, press with a dry gauze, then first with the finger, then with the periosteal elevator, and then stretch the soft tissue for closure immediately. Of course, do not use fast resolvable suture, and removable appliance should not be used. Now, let's see what we should respect in the clinical situation. There are 5 protocols. 2 of them refer to socket grafting, 1 of them to lateral augmentation, and 1 of them to sinus lift. Socket grafting, there are 2 protocols. 1 is without flap reflection, and the other is with flap reflection. Lateral augmentation, just 1 protocol, and sinus lift, we have 2, 1 for open, and the second is for closed sinus lift. When we decide to do socket grafting without flap reflection and when with flap reflection. Without flap reflection, we can do it when we have 4 bony walls. This is absolutely not a problem. We inject the material into the site, press from the cervical part, and that's all, and protect it, of course. When we don't have the buccal plate, then it's very recommendable to reflect a minimal flap, to apply the material and then compact it well until it reaches the bottom of the socket, buccally and occlusally. That is very important. When we have 4 bony wall, it's not important if the material didn't reach the bottom of the socket, because the blood clot will do the work for us. However, when we have a missing of buccal plate, we must compact the material all the way down, okay? Now let's see about socket grafting. One thing is important in socket when we extract the tooth is not to aspirate the blood. For example, when we have blood at the bottom of the socket, we shouldn't aspirate it. The blood is very important for the regeneration process. Therefore, do not aspirate it. It's very, very, very important. So we leave the blood inside, then we inject the material. And immediately after injecting it, we should press it with the unfolded gauze, first with the finger for 3 seconds on the gauze, and then with a periosteal elevator. Remember, material that will not be well compacted at the cervical zone might generate discomfort to the patient 4 days later due to the floating of the material. So it's very important. It's very simple, as you can see, but you must respect it. So it's very important. First, we press with the finger and then with a periosteal elevator. Do we need to push it down until the apex in 4 bony walls? No, absolutely no. It's enough that it will be in the cervical part. But when we don't have a buccal plate, then the second protocol with flap reflection is recommended. Now, a material that is exposed more than 3 millimeters must be protected in such cases. Sometimes before we protect it, it gets soaked with blood. So what we do, we take again the dry gauze, press for 1-2 seconds, and then we continue to protect it. Later on in my presentation, I will show how we protect it. Material cannot be left, the cement cannot be left exposed more than 3 millimeters without protection. Otherwise, it will wash out and you will lose volume. The other mistake might be in the application of the material. Okay? Sometimes, some doctors ask me why the material does not go out from the syringe. The reason is very simple. If you block the aperture of the syringe, definitely the material will not go out and it will be stuck in the syringe because you need to let him some space to go out. So in order to overcome this drawback, what we are doing, we incline the syringe in 45 degrees angle, as you can see here, and then the material goes out very easily and fill the socket. So make sure not to block the aperture of the syringe. Okay? The other mistake that I saw, that because clinicians are used to work with granules, so what they are doing, after injecting the cement, they start playing with it like with granules. And this is a big mistake, because immediately after injecting the cement, you should take a dry gauze, place above, press firmly for 3 seconds, and then take a periosteal elevator on the gauze for additional compaction of 2-3 seconds. Okay? So don't play with the material like granules. It is not granules, it's worked differently. Therefore, its protocol should be respected. Now, how we apply the pressure? Don't play with it. You see, this is wrong. The only thing that you need to do is to place the gauze and press firmly and decisively. That's all. Like here. You place, press firmly and decisively, 3 seconds, then use the periosteal elevator or spatula in order to add additional compaction. Those small things make the difference. Now let's see it on a patient. We push slowly the shaft until the first piston reaches the blue line, remove the cap, and then injecting the material into the site, taking a dry gauze, press firmly for 3 seconds, then take a periosteal elevator, add firmly additional compaction. Now we can remove access and we are ready to protect it. Remember, we cannot leave the material without protection. Now, how we protect it? There are 2 ways to protect it. One is by collagen sponge or collagen plug, and the other is by wound dressing, which is the Bova-Aid or Ogma Shield. Okay? So, if you leave the cement exposed and you just make a sutures, for sure, the material will wash out and then you lose volume. It will never get contaminated due to exposure, but you will lose volume. So we can avoid it by protecting. And in my next slide, I will show how we protect it. Okay, so you see, just suturing, definitely it's not enough. And this is completely wrong. Now, how we protect it? We take a simple collagen sponge. In the US, we're using the Matrix Derm collagen sponge. We squeeze it. We adapt it to the size of the socket, and then we secure it outside of the oral cavity. Because if we try to secure it first in the oral cavity, it will get embedded with blood and it will be very difficult. Then what we are doing, we suture it buccally and occlusally and secure it with a cross suturing. The collagen sponge should be well protected. Now, there is something which is very important. Normally, when we use with membranes, we need to undermine the membrane. Here, no, it shouldn't be undermined. It should be placed on top of the gum, okay? And it's not important if it's perfectly adapted or not, because again, if it's a little bit exposed, nothing will happen, but it should be placed on top. Let's see it here on a clinical case. After removing the excess, we take a collagen sponge, we hold it in our hand, go from one side to the other with the needle. Then place it on top of the gum. We don't undermine. Go buccally and lingually into the gums and make suture and then a cross suturing above. It doesn't look so nice as you can see it here, but it's extremely effective. It's very important that it will be well secured. Otherwise, the patient will take it out and everything will wash out. That's how it looks after 7 days. And now you're going to see how it looks after 3 months. When the material is protected, it will transform into the patient on bone. That's the soft tissue appearance. And at the re-entry, we can see that we have the wonderful result of truly bone of the patient. Here and there, we might find some particles of the HA, which resolve with the time. But as you can see, most of the sites, more than 90% in this stage is the patient on bone. And from our histology, after 8 months, almost everything is the patient on bone. The other option is the ORA, the adhesive band, or the Ogma shield. As you can see, after that we remove the axis, we place it, it sticks very nicely. So it's very easy to work. Unfortunately, we don't have it in the US now, but we have it in Europe and in Israel. And we need to secure it. Now, how do we secure it? We go from mesial underneath the adhesive band, we go from mesial to distal, and then lingually from mesial to distal, and then we do a cross suturing just to keep it in place. That will work. That will do the work. Okay. After about 10 days or 12 days or 14 days, you can decide, if you see that everything is closed, to take it out. Most of it is resolved already at that time. You can see it here in this case, okay, after the extraction, we place the bond apatite. It must be protected. So we use the adhesive band here, as you can see it here. We secure it, we go mesially with the suture to distal, and then on top of it, again, also the adhesive band should not be undermined. It should be on top of the gum, because if we undermine, we delay the healing. We want to let the soft tissue to proliferate directly on the cement, which is done very nicely by the nature, okay? So we don't want to inhibit the healing, we place it above, and the only thing that we do, we secure it, otherwise the adhesive band will fail after 4 hours. So we want it to stay there for at least 10 days, 7 days, something like that. That's how it looks 7 days post-op, okay? And here you can see how the soft tissue looks 3 months post-op. You can see that everything is keratinized tissue because on top of the cement, the keratinized tissue has proliferated. And of course, we can see in the CBCT the outcome of the bone, and the re-entry. You can see we can find still some particles of HA which are in the process of resorption. They look like bubbles in this stage. Those are the big particles of the bond apatite, because bond apatite is composed of biphasic calcium sulfate and HA in a different particle size distribution that resorb as well. The HA do not stay there. And all of the histology show it, and all of the process of resorption show it. And of course, when we drill and place the implant, we can see that we drill into a vital bone. Now, errors of not respecting the protocols might be also errors of surgical approach, okay? For example, if we make the vertical incision too close to the bone deficit, such as in this case, we can see that we have here a big defect with missing of the buccal plate. Of course, in such cases, we need to reflect the flap. Here, there was a mistake that done. Normally, we should, if we want to make our vertical incision, it should be in a distance from the area of the defect, because here we have the defect, it should be at least here. And we should not go more than 3 millimeters beyond the mucogingival junction. Here, it was done on the defect. Of course, it's a mistake and we're going to pay for it. We place the bone appetite, we stretch the soft tissue. 3 months later, that's the soft tissue appearance. However, here we see the depression due to the fact that the vertical incision was done here on the defect. It should be a little bit in the distance. So at the re-entry, we see that we have a wonderful bone here. However, here we have some deficiency. Of course, we can add a little bit more bone and do it a little bit differently. Here you can see that the same mistake was done at the first time and the second time, at the re-entry and at this. And of course, you can see here the depression of the soft tissue. This is something that can be avoided very, very, very easily. Now let's speak about lateral augmentation and crest widening. Lateral augmentation is a different opera, because in lateral augmentation, we have a different situation, different clinical situation. Also, in lateral augmentation, it's much more difficult to stabilize the flap, that it will not move on the top of the graft, and every movement might jeopardize the graft, okay? And in lateral augmentation, there are no bony frame that from one point of view will give us support to the graft, and from the other point of view will provide us cells and blood vessels to the site. Therefore, it's much more challenging, and we need to realize that those cases, for example, when we don't have any spongy bone and everything is cortical plate, it's not the same as this case when we have sufficient spongy bone and a narrow cortical plate, because here it's much more challenging, and definitely you shouldn't promise your patient that you're going to be successful in one time. So don't raise his expectation in those cases, because definitely it might be that in the challenging cases that you will need a second time, and sometimes in a very challenging, maybe even a third time, in order to gain a nice volume. So this is something that we should realize and should be aware of. Again, the flap should be minimally reflected as needed to expose the defect. What do I mean by that? We can see it here in the animation. As you can see here, when we do the vertical cut, it should not go beyond the mucogingival line in more than 3 millimeters. Then we introduce the periostal elevator in order to reflect the flap. And we dig down 3 millimeters into the mobile mucosa. Okay? Now, if there is a place that there is a defect that is more than 3 millimeters, then you go all the way down until you expose the defect. That's very important, but all the other parts should be no more than 3 millimeters. You see, like this. Now, immediately after, we take the forceps and we stretch the flap. The mobile mucosa will enable us to stretch 3 millimeters into the mobile mucosa, will enable us to stretch at least 6 millimeters. Okay, so don't be afraid to stretch. This is something that we never did before, but with bone cement, this is the way how to do it. We don't perform any periostal releasing incision. It's very important to remember. Now, if you need to stretch a little bit more, just go 1 more millimeter with the periostal elevator beyond the mucogingival line, but you don't need more. With that, you can close almost everything. You can see it here on patient. Now remember, when we are only 3 millimeters beyond the mucogingival junction and the mucogingival line, Actually, the muscle is not connected to the flap. The muscle's movement will not influence the flap. Therefore, nothing is going to open the flap. So here you can see what we are doing. We stretch. You can see that it can be stretched very nicely and can cover almost everything. After that, we perform a decortication. It is very important to do a deep decortication in order to go to the spongy bone. And then, just then, when everything is clean and ready, we activate the bone appetite syringe. We place the shaft in the palm of our hand, our finger at the top on the cap, and then slowly we advance the shaft until the first piston reaches the blue line. Then by twisting and pulling motion, we remove the cap. And then we change position and place the shaft between our two fingers. We grasp the handles, and then in 45 degrees angle, we start to eject the cement and using the head of the cement to compact it in place. As you can see, it's a continuous motion in which when the material cannot go out anymore, we change position. We use the thumb of our hand to expel the rest of the material into the side. Immediately after, we take a dry, unfolded gauze, as you can see here, and we press with our finger, buccally and occlusally. From all sides, it's very, very, very important that the material will be well compacted. Okay, then we take a periostal elevator for additional compaction of 2-3 seconds. That's all. We remove the gauze and then immediately go to closure. Now we see it on a patient. We activate the bone appetite, as we showed earlier, 45 degrees angle. We eject the cement. Remember, after ejecting the cement, immediately you should press on it. Immediately. Don't wait. First with the finger, then the periostal elevator, buccally and occlusally. Add an additional layer if needed. Press strongly, buccally and occlusally. Slightly overfill to compensate for shrinkage. Now the cement stays very nicely. You can remove excess. Don't play with the cement. Just remove the excess and then continue for soft tissue closure. Okay? So how you do the soft tissue closure? You stretch the mesial corner and suture, then the distal corner, then the middle, then in between, and finally the vertical incision. The sequence of suturing is very, very important. Otherwise, it will never get closed. So as you can see, we stretch and we start suturing. 3 millimeters of graft exposure. It's completely fine, but don't leave it more exposed than 3 millimeters. As you can see, this procedure is by far less invasive, and we do the predictability test. What you can see here, we move the vestibule to see that our suture do not move. That shows that the muscle is not connected to the flap, and that shows us that actually the graft will be very stable. Of course, we don't use a removable, but the graft will be very stable and nothing is going to open the area. That's why it's enough for us to do simple suture. We don't need to do mattress sutures. We don't need to try to do any complex way of suturing. Just simple suture are enough because the muscle is not connected. Okay, here, for example, it's a challenging case, as you can see. And even if we have from side to side to do grafting for lateral augmentation, we finish one side, we place the graft and immediately suture it, and then we go to the other side. Actually, we can open everything in one time, but after placing the material, the first thing that we need to do to close the area and then go to the other side. Okay, here we can see that it's a very narrow ridge. The bone appetite was placed and very well pressed from both sides. The flap is minimally reflected, okay? And then after 3 months, we can place the implant. Of course, in lateral augmentation, I do recommend to wait even more than 3 months. In 4 months, 5 months, you will have much better bone, much stronger bone than in 3 months. However, in most of cases, also in 3 months, you can load, but I recommend 4 or 5 months, you will have even much consolidated bone and much more calcified. Again, as I mentioned earlier, do not do any periostal releasing incision to gain tension free, okay? Those are mistakes that was done in the early days when we didn't know the protocol. So actually in those days we worked like with traditional grafting. However, we perform here a very large flap, okay? And place the bone appetite. And of course, the movement of the muscles influence the results. And as you can see here, we have a big retraction of the area. Okay, and of course, we lost everything. So it's not a big deal because it does not get infected, because we don't use membranes here and we don't have material that is infected. The material is bacterial static. However, we didn't get the volume. So in this case, we learned how to do it in the right way. So here, the flap was minimally reflected. There was no periostal releasing incision. It was stretched to place. Okay, and after 3 months, we got a nice bone here. It's still a very young bone, but definitely implant can be placed. Now, do not forget the predictability test. The predictability test actually show you first if you reflect the flap in the right way. Okay, if you didn't perform a too large a flap, of course. Now you know that no periostal releasing incision should be done and no releasing in the connective tissue should be done. But again, when you reflect the flap, you can check if you did it in the right way. It's in the predictability test. It's after that you close the area, you place your finger in the vestibule and vibrate the muscles. If the suture do not move at all, that's perfect. However, sometimes we have situation in which the predictability test in some place shows us very nicely. However, in the other, it shows that it moves the sutures. Why it moved the sutures here? Because we have the frenum here. So in case that we have a frenum, in order to avoid the opening of the area, we should cut the frenum. Just take a forceps and cut it. That's all. If not, what you're going to see that after 2-3 days, it might get exposed here. You see in the back part, it didn't get exposed at all. But here it was exposed due to the frenum. So it's not a big deal. What we can do now, we can cut the frenum and make some sutures and of course let it heal. And after 3 months, we have a very nice results. Again, one of the biggest benefits, you don't have the traditional complication of infection due to exposure. That's very important. And of course, if you don't have the infection, you don't lose hard tissue, you don't lose soft tissue. So that's a big advantage. The other mistakes that can be is a poor case analysis. Poor case analysis is when we don't analyze the case and we treat it like we should treat a different protocol. For example, this case, we see a big defect that the teeth was extracted without flap reflection. We didn't evaluate here that there was no buccal plate, okay? And we can see here that after 3 months, still the defect remained. And when it's open, we can see some bone here, but definitely it's not enough. But when we open, we see that there is a big defect that was unfilled. So in this stage, due to the fact that we got some bone here in the cervical part, we can place the implant, and now we must place the bone appetite and compact it very well against the walls of the implant, okay? And close the flap. And of course, after 3 months, we can load it. That's how it looks in the radiography. Now, in sinus lift, of course, we can do intraoral sinus lift and intracrestal sinus lift and open sinus lift. I will not go to the protocols because this is something that will take a long time to speak about it. So just a few small things to mention. Of course, when we do intracrestal sinus lift, if we have less than 4 millimeters and we try to place the implant, probably we will find it in other places. It will float in the sinus. And as you can see, it can float everywhere. So normally, if you want to place the implant at the same time for intracrestal sinus lift, we should have at least 4 millimeters of width of bone, and then we can place an implant. There is a very nice technique of Dr. David Baranes that is going to publish it, in which you can do intracrestal sinus lift in 1 millimeter. However, you do it in 2 stages. The first stage is a stage in which you gain the first 4 millimeters, and just in the second stage, you place the implant. I highly recommend you to follow when Dr. Baranes will give his lecture about this protocol. Very nice, and actually it's safe for the patient, much more aggressive surgical procedure as a lateral sinus lift. Okay? Of course, only fixed prosthetics should be used. Here we can see a case when a removable flipper was used. Of course, if there is a removable flipper, we will have some resorption, and you can see it. And we can try to fix it in the second time, but again, it's much more difficult to fix something like that. So it's better to avoid it than to try to fix it. And as you can see, it's not perfect result due to the fact that already there was a resorption in the area. Of course, if you avoid using of removable denture, and at the first stage you have the papilla in place, you can use or the collagen sponge or the collagen sponge together with the Augma shield or the Ora aid, okay, to protect it, okay? And you can use a Maryland bridge, temporary Maryland bridge. And I want you to see that the papilla now is here exactly in this place. You're going to see there will be zero resorption of the papilla, and all of this exposed area will be proliferated by new keratinized tissue. Okay, that's how it looks after 1 week, and you can see that the margin of the gingiva is here, but of course, due to the proliferation, it grows very nicely. The papilla is perfectly in place. Of course, if there was not the composite here that butter the papilla to gain up until here, it will reach up until here without any doubt. Okay. Now we need to remember that the material is bacteriostatic, which helps us a lot. And as I said, due to exposure, we never encounter even one case of infection. Of course, it can get infected if we place it in infected area. If we work with the infected cell line out of during the procedure or this, but due to exposure, we never encounter infection. But we need to know not to push too much the border. For example, here we have a large infected area, okay? And after removing the granulation tissue, in such case, it doesn't say that we cannot place the bond appetite, but placing the bond appetite and placing the implant simultaneously, it will jeopardize the outcome in such case. For example, as was here, the implant was placed and the bond appetite on this, and of course, we didn't get the results that we wanted here. So what needed to be done? The implant was removed, bond appetite was placed, well compacted, and of course, later on, implant can be placed. In the second stage, and the reconstruction. Now, in cases of the essence, we need to remember that when we have exposed threads, the predictability of the outcome, it's much more better when we have bony frame, as we have here, than when all the threads are completely exposed and the soft tissue might move here. So let's see what happened. Of course, we can see that bone was grown here, but here we have exposed thread. Therefore, in such cases, we highly recommend or to submerge the implant or just do it in 2 stages. Here, when it's within the bony frame, absolutely not a problem. But when it's out of the bony frame, it's much more sensitive. So augmentation was performed, and later on, another implant was placed. Of course, in the aesthetic zone, we cannot compromise the area by exposed threads. So in conclusion, there are some, let's say, unsatisfactory result that might happen due to the patient. For example, when the patient don't respect, don't comply with our instructions, or when the patient is medically compromised or highly smoker or something like that. Okay, but in such cases, what we can do if we didn't get the right result due to the fact that the material does not get contaminated, the worst case scenario, we can start over again. Okay, and without any fear. And in the second stage, from our experience, you will have a much better results than from the first time. The other cause can be due to lack of knowledge of the doctor or not respecting the protocols. Of course, respecting the protocols will increase the success without any doubt. So I would like to thank you for your attention, and I highly recommend you to go to abca@augmabio.com, Augma Bone Cement Academy @augmabio.com. There you can find a lot of clinical cases. You can find our ebook. You can find webinars with different cases, with different protocols from different clinicians, from our bone cement expert. So that's something that can expand your knowledge. And of course, for any question that you might have, you are very welcome to write us or to contact us, and we will do our best to answer each one of you. Thank you very much.
Thank you very much. A few important notes before we jump to the Q&A. You will receive an email with a request to fill in the feedback form. The feedback helps us to create new educational content, so we would appreciate if you would take a minute to respond. If you are a US clinician, you also get a short description on how to claim your CE credit. We invite you to join our international group on Telegram to hear about upcoming events, view clinical cases, and conduct clinical discussions. You can sign up to augmabio.com to watch on-demand webinars, clinical cases from Augma's bone cement experts, and scientific literature and research. Currently, we have more than 15 on-demand webinars in English, Spanish, and French. US clinicians who complete a webinar receive complimentary CE credits. You can also see more cases by our bone cement experts at augmabio.com. You can address any follow-up questions to info@augmabio.com, and we will reply shortly. And now for the Q&A. When then would you go in for a second lateral augmentation?
I recommend to go in for the second lateral augmentation, for example, after about 4 months normally, okay? If we need to add more. Also for implant placement, about 4 or 5 months.
Okay. As a periodontist, I get referrals from general dentists to treat perioimplantitis cases. Can bone cements be used for treating bone defects in these cases?
We have some very nice cases of periimplantitis. However, we don't have a predictable protocol. So until we will not have a predictable protocol with sufficient clinical evidence statistically, we prefer not to recommend it for periimplantitis, because periimplantitis, it's quite complicated situation in which it's not just that the implant himself is affected, it's also the morphology of the defect. So I prefer at this stage not to recommend to do periimplantitis cases, even so that from time to time we show what we achieved, but still we don't have a protocol, so we don't recommend it in this stage. The same is with vertical augmentation. Okay, all of those protocols that you saw here, if you respect them, you might end up with 95% of success. However, with periimplantitis, I cannot say it because still we don't have enough sufficient data for that. So in this moment, I actually don't give any specific protocol for this.
Okay, when suturing, how far from the edge of the crestal incision would the needle enter the tissue?
It can be even 2 millimeters, not more than this, because the muscle is not engaged. When the muscle is not engaged, there is no fear that the suture will tear the soft tissue. Normally, when the muscle is engaged, as with traditional grafting, definitely you should go a little bit far, and then you should add some mattress suture. Here, 2 millimeters, 3 millimeters is completely fine.
Okay. An orthodontist has referred a case to me where because of aggressive orthodontic movement, several roots of the anterior teeth in the maxilla were moved buccally. CBCT showed several dehiscences. Can bone appetite be used through a tunnel technique to augment over the reabsorbed bone?
Yes, without any doubt. And actually, you can do it by tunneling technique. But when you do the tunneling technique, you should remember to compact the material, which means that you inject it into the tunnel, take a dry gauze, and then take the mirror handle or something and push it into the tunnel, and then add another layer on this. However, due to the fact that we are not using a membrane here, and due to the fact that we don't need to do tension-free flap, just stretching it, even if you reflect the flap or do an envelope technique, it will let you to do it much more easily, because then you can compact it very well and very easily, and then just stretch and suture. And without any doubt, it's helped very nicely in such cases.
Okay. I used bone plaster in the 1980s for periodontal cases, and it worked well. What is the difference between the old plaster of the 1980s and this material?
First, bone plaster is very well known for more than 120 years. One of the benefits of bone plaster that actually it transforms into the patient own bone. The problem is that it resorbs too fast, therefore it is limited for small defect, and actually it does not set in the presence of blood and saliva. Bone plaster actually is calcium sulfate. Our product is calcium sulfate. The only difference that after 100 years is the patent of biphasic calcium sulfate. Biphasic calcium sulfate used the two phases of calcium sulfate in one product, which is not a combination, it's actually within the product. Therefore, the only calcium sulfate that can set immediately in the presence of blood and saliva is the biphasic calcium sulfate. And due to the fact that it can set, also it has much more predictable resorption pattern. Now, the point is that if we use the biphasic calcium sulfate alone, by itself, it can be used just for small defects such as socket grafting. For larger defect, you need a composite graft. The bone appetite is a composite graft, which is made of 2/3 of biphasic calcium sulfate that has the ability to set and to behave like cement in the presence of blood and saliva, and 1/3 of hydroxyapatite. Now, hydroxyapatite by itself, it's the worst material to be used as a graft material because it's not supposed to resorb. The integration is not perfect and all of these things. But here, we use the high density hydroxyapatite that's not supposed to integrate. Instead, It resolved due to the particle size distribution, which have also different sizes and its shapes. So actually what happened here, it's a very interesting process that the small particles to medium size are resolved within 3-4 months, and the larger particles, most of them after 8 months, are completely resolved. So that's one of the benefits of the bond appetite compared to the traditional plaster. Because plaster, without any doubt, it's a material that has a lot of advantages. The problem is that it could not set in the presence of blood and saliva, and it's resolved too fast. And when it could not set in the presence of blood and saliva, the resorption pattern was not predictable. That's why it was very difficult to work with it. That clinician should work layer by layers. If he wants to make a defect, he should mix it with potassium phosphate in order to accelerate the setting, and even then it didn't set. The only calcium sulfate that can set is the biphasic one, and that's the pattern. That's what makes the difference.
Thank you so much, Dr. Amos, for this wonderful presentation. And thank you everyone for joining us today. For more information, you can come to augmabio.com or send any questions to info@augmabio.com, and we will reply shortly. Have a wonderful evening.
Thank you very much.
Thank you.
Very much.
Thank you.